Hi, my name's Betsan, one of the consultant clinical oncologists working in Velindre Cancer Centre, which is the cancer centre based in Cardiff, in Whitchurch, just down the road. So thank you for asking me to speak today. Our specialist nurse, Donna Lee, was going to come and join me and introduce herself to you as well, but unfortunately she's unwell, so it's just going to be me presenting today. First of all, just thank you for asking me to speak. It's always nice to speak to patients and carers and get to know people. But it is sometimes a bit difficult to know where to sort of pitch the talk, depending on geography, where you guys are from, how far you've travelled, because some of the contents will be specific to Wales. But also where you are in your sort of GIST diagnosis pathway or journey. You know, some of what I'm talking about may or may not be relevant to you. But I'm hoping everyone will gain something from my talk at least. So I've been asked to talk about GIST cancer in Wales, but also treatment trials and support that we can offer locally in Velindre Cancer Centre. But I will touch upon pathways across Wales as well. So some of you will be very familiar with this, but others, it may be a new diagnosis and you're still trying to come to terms with, what it means for you. So GIST, gastrointestinal stromal tumour. It is a malignant tumour, and sometimes I find that patients tell me that they've been told by other members of the team that it's actually not malignant, that it's benign, and sometimes that terminology can be a little bit confusing. But malignant is another word for cancerous because it is a cancerous tumour. But fortunately, some GISTs at least act in a relatively benign fashion. And by what I mean by that is that they can be slow growing and may not necessarily come to any direct harm from that GIST, depending on whether it was a very low grade or very small GIST in an area that isn't causing any concern. But there is a spectrum, so some will have ones that are very slow growing, and other people may have one that are sort of growing faster and can act in a more aggressive fashion. So it is important to remember that it can be a spectrum. The sort of sciencey bit originates from the pacemaker cells in the gut, and these are the cells that regulate the movement of food and fluid through the digestive tract. And on the right-hand side, there's a diagram of the cells of Cajal. Thank you. It is a very rare cancer. There's 700 new cases roughly per year in the UK, with between 30 and 60 new cases per year in Wales. The age range can vary, but the median, so the average, is between the age of 60 and 65 at the time of diagnosis. And the symptoms can be very variable, and that's why sometimes it can take a long time to diagnose, and some of you may have found that there were some difficulties getting the diagnosis confirmed. It can present with pain and bleeding. That's probably the two most common symptoms, but also sickness or nausea and vomiting, swollen or distended abdomen or tummy as well. Quite complex diagnostic pathways, so lots of staging investigations, lots of tests to get to the ultimate diagnosis. And the care plans can be quite complex as well, which need to be individualised for the patient in front of you. So GIST can occur anywhere along the digestive tract. The vast majority are in the stomach, but we also see them in the small intestine, the esophagus, the colon or the rectum, or the omentum or the mesentery, which is the lining of the abdomen essentially. So our aim in Wales is to deliver the most safe and effective specialist care as locally as possible, which is a little bit confusing, but some of you are probably aware that there are 7 health boards in Wales. And we aim to we aim to have tests and treatment done as locally as possible. But there may be situations where you are asked to travel for those tests or treatment because it's such a specialist service that we provide in the management of GIST cancer because it is rare. And so not every health board will necessarily have access to the most specialist tests or treatment in your local hospital. Sorry, just go back once more. No, it's fine. So just to say that if you have been to see an oncologist, there are 3 cancer centres in Wales. There's one in Singleton Hospital, one in Velindre Cancer Centre in Cardiff, and another one up in North Wales in Glenclwyd Hospital. So if you are asked to see an oncologist, you may need to travel for that appointment. Some oncologists do peripheral clinics in your local hospital, but others are very much centred in the cancer centre, which is why you may need to travel. So I chair the Regional Specialist GIST MDT, the multidisciplinary team meeting, and that's for South Wales. So North Wales have a slightly different pathway. But as part of that team, there's a range of specialists, and we aim to manage patients with GIST. So we take care of the diagnosis, any genetic testing that may be required, treatment, whether that's surgery or non-surgical. We coordinate clinical trials, whether that's locally, regionally, or nationally. We also come up with a sort of individualised follow-up plan for patients, talk a little bit about survivorship. So, you know, once you've completed your treatment, what specialist care you may need thereafter, depending on what treatment you've had and what side effects you may have. And we also have the access to supportive care teams as well. So meet the team. This is for South Wales, so it's not going to be relevant for some of you, but it's quite interesting to know what happens behind the scenes sometimes, because these are specialists that you may never meet in person. It is important to say for every specialist I've named there, so allied healthcare professionals, nurses, doctors, there is a team, but some people have got more pictures online than others. So I've just put a picture of a few of the local specialists that we have. So radiologists, the first picture there is Dr. George Joseph. He's our GIST radiologist working in Velindre Cancer Centre. Pathologists, so they're the people who work in the lab. They don't normally meet the patients. It's all very much lab-based. So the picture on the top right-hand corner there is Dr. Adam Christian. He's our pathology lead, and he's excellent. You may have had surgery or awaiting surgery, so you will have met a surgeon. More often than not, there will be a gastrointestinal surgeon, a GI surgeon. And the picture I've got there just under on the right is of Mr. Guy Blackshaw. So he's one of our lead surgeons for GIST. But you may have surgery in your local hospital. You may need to travel for it if it's centralised. So depending on what op you need. A gastroenterologist, they tend to be leading the diagnosis of GIST if you've needed an endoscopy. And there's a picture of Dr. Hassan Haboubi. He's one of our lead gastroenterologists, and he's based in Llandoch Hospital. Then you may meet an oncologist. There are two types. You may not know the difference, but a medical oncologist tend to deal just with the systemic treatment. So they will deal with the oral therapy or medicine that you need for GIST. But there's also consultant clinical oncologists. And I'm a clinical oncologist, which means I deal not only with medicines or drugs, but also with radiotherapy as well. So if you need radiotherapy, which I'll talk to you a little bit about, then that would be delivered by a clinical oncologist. And I've got a picture there on the bottom right. That's Dr. Sarah Gwynn. That's one of the oncologists that works in Swansea Cancer Centre. That's part of the GIST MDT. In clinic, we have access to a specialist GI dietitian, which is just incredibly helpful, especially if you've had bowel surgery or any surgery along the digestive tract, or if you're on medicines that can cause any problems with side effects of the gut, then it's really important to optimize your nutrition. So the picture just on top there is of Amanda, our specialist GI dietitian. And some of you may have a GIST that unfortunately we can't cure, but we're trying our best to support you through it. And you may have some symptom control issues. So then we tap into specialist help from the palliative care team. And on the bottom left, that's Professor Mark Talbot. He's one of our palliative care consultants. Okay. But we also work in close collaboration with the All Wales Medical Genomics Service. So they take care of the diagnostic, genetic testing, screening. And if we need any clinical genetics advice, we'll be referring you to their service. We have a clinical trials unit based in Velindre, but we also work alongside the trials unit in the Marsden. And I sometimes, if I haven't got a trial open locally, I'll refer to Professor Robin Jones, who we've heard about today. And he will often tell me what trials there are available and if I've got any suitable patients. And we try and streamline the referral pathway. And then, of course, we work closely with sort of patient carer supporter groups and charities, as well as Maggie's, which is based actually in the car park in Velindre Cancer Centre. And that's an excellent sort of support service for patients and carers. So tests, some of you will have already been through all of this and know it all already. Others may have had some but not all of these tests. But what we frequently use to diagnose GIST is an endoscope. And that's on the top there. That's a camera at the end of a small tube that's inserted either through the mouth or through the back passage to visualize the GI tract, the digestive tract. Sometimes we use an ultrasound, an endoscopic ultrasound, so it's a similar probe, but with at the tip of it, there's a small ultrasound probe that can take pictures of the digestive tract, and the pictures you can see there on the top right. You may have had a CT scan or a PET scan that uses radioactive glucose that is absorbed by the metabolically active or quickly dividing cells. And a picture of the PET scan there just below the endoscope, and that's what lights up. And then sometimes you'll need an MRI scan, which is the magnetic scan, which is a picture of that on the bottom right. So this is a picture that we may see at endoscopy of a GIST. So that's the lining of the esophagus there. And then you see a sort of smooth, well-rounded, well-defined lump, for want of a better word. And that's typical of a small GIST somewhere along the GI tract. Once we've got a diagnosis of a GIST, we'll often do a CT scan just to see if it has spread elsewhere or whether it's localized or contained. And you may not have looked at pictures of CT scans before, so this is cross-sectional through the body. Head's normally at the top, legs are on the bottom. And on the left is quite typical appearance of a small localized gastric or stomach GIST, a sort of well-defined nodule. And on the right, a picture of a sort of more advanced GIST, because it can actually grow, a GIST can grow to quite some size in the abdomen without causing so many problems, because there's just so much space. So it actually can get to quite a large size before it presents with any symptoms, up to 10 centimeters sometimes. And that's a picture of a larger abdominal GIST with some fluid and necrosis in the middle of it, which is the sort of black stripy bit in the middle, with some calcification around the edges. So that's the sort of white spots you see around the edge. Once we've seen what looks like a GIST, we then do a biopsy, and then we send that to the path lab, and the pathologist will do some sort of specialist staining tests to see whether this is consistent with a GIST. You don't really need to know this, but the stains that they will use is DOG1, discovered on GIST1, and CD117, and the vast majority of GIST will have a positive stain reaction to these tests. So we're normally fairly certain then that we're dealing with a GIST. But the pathologist will also tell us about the mitotic rate, and that measures how quickly the cells are dividing and growing. Once we've got that diagnosis, we then send it to the genetic lab, the All Wales Medical Genetic Service, and we ask for a mutation analysis. And I know a lot of you will already be aware of this, but that will confirm the diagnosis if there's any uncertainty on the staining tests. But it will also give us the type of mutation, so the type of genetic change or alteration in your specific GIST, which will then predict sensitivity to targeted therapy. By targeted therapy, what I really mean is a tyrosine kinase inhibitor that you probably will have heard of, either imatinib, sunitinib, or regorafenib, for example. The vast majority will have a mutation in the KIT gene, but it can, where that mutation is, and depending on which exon, you don't need to worry too much about, but that will tell us, where that mutation is will also predict how sensitive you're likely to, how likely you are to respond to imatinib. So 75% will have a KIT mutation, 10% will have a PDGFRA mutation, but 15% will be what we call wild-type tumours, which is a bit of a funny term, especially if you haven't heard it before. But basically what we mean by that is that it doesn't have those two common mutations. And then we do some additional tests then to see if that GIST may have another rare mutation that is not commonly seen. And to get that further analysis, we often need to send that pathology sample to a different lab. So we don't do those additional tests in Cardiff. We can send them, for example, to a lab in Birmingham. And then on the right is an example of the mutational analysis report that we have. But in summary, in conclusion, as you see in that box there, this particular patient had probably the most common mutation, which is in the KIT gene, exon 11. And patients with that particular type of mutation tend to respond quite well to imatinib. Okay. So treatment, these are the guidelines, so you'd be pleased to know that we do tend to follow guidelines to make sure that what we do is sort of evidence-based and recommended, safe and effective. So these are actually the European Society of Medical Oncology guidelines. So this is a committee with representatives from all across Europe and the UK that sit on that committee, and basically they look at all the data that they've got so far and they come up with recommended guidelines that we try to follow as closely as possible, but there will be some circumstances where treatment may not be funded or licensed in the UK, for example. But I don't think we're doing too badly, but there are some specific drugs we don't have available at this time, and I'll come on to that in a second. So this is for localized GIST. So what I mean by that is GIST that hasn't spread elsewhere and that we think may be amenable to surgery, to an operation. So if it's a localized GIST, and if you've done your mutation analysis and we think it's got an imatinib sensitive mutation, if the surgeon thinks, so on the left-hand side there, if the surgeon thinks they can do an operation with no major consequences up front, then the mainstay of treatment then would be surgery, and that's a curative surgery with curative intent. If they do the surgery and they're happy that they've removed it all, the margins are all clear, they'll send that sample to the path lab, and then the pathologist will do a number of different tests, and they'll tell us whether they think it's a low or intermediate risk of recurrence of it coming back, or whether it's a high risk of recurrence. And that's based on not just the size of the GIST, but the location in the GI tract, and also the mitotic count, so how quickly those cells were growing when they're in situ. If it's a low or intermediate risk, we recommend surgical follow-up. If it's a high risk, then we recommend adjuvant imatinib. So by adjuvant, it's just additional treatment to try and prevent the risk of recurrence. At the moment, we're recommending treatment for 3 years, but there is a study going on at the moment, a Scandinavian study looking at whether 3 or 5 years will lead to better outcomes. If we've done the scans and the GIST is localized, it hasn't spread elsewhere, but the surgeon thinks if I went in there now, I may not be able to remove the whole tumour, then sometimes I'll refer you to an oncologist to give you some treatment up front, some pre-operative imatinib, to see if we can shrink the tumour and increase the chances of truly successful surgery with nice clear margins. So some people will have a course of imatinib before surgery. If surgery is then an option, again, the pathologist will tell us whether it's low, intermediate or high risk of recurrence. But if surgery is not feasible, then we'll go to the next set of guidelines, which looks at non-surgical GIST, so GIST that where an op is not an option, or whether it's spread to elsewhere in the body. And this is where it gets a little bit more complicated. So this is advanced or metastatic GISTs. So it all depends on whether you've got a sensitizing mutation. So that's on the left-hand side of the algorithm here. So if you follow it down, if you've got an imatinib-sensitive mutation, then we'd recommend imatinib 400 milligrams. If there's an exon 9 mutation, so I'm not sure if you remember in the last diagram, there's different exons that can have different mutations. There is some evidence that if you've got an exon 9 mutation, you may be sensitive to imatinib, but you may need it at a higher dose of 800 milligrams because it just takes a higher dose to get that response. Now, that is something that is not currently approved by what we call NICE, so National Institute for Health and Care Excellence. They're a committee that tell the NHS, both in England and Wales, whether a drug is funded or approved. And they have said that they don't think there's quite enough evidence to recommend 800 milligrams for everyone with a KIT9 mutation, exon 9 mutation. But it can be an individual discussion. You know, you can do an individual patient funding request if you think it would be of true value there. If there is a response, then we would continue imatinib. If there's a very good response and we think the disease is now operable, then we may recommend surgery for any residual disease. If there's no response, there's two different categories. You may have a limited progression. By that I mean that The majority of the GIST is responding to the imatinib, but there may be one particular area that's growing despite treatment. If we think that one particular area is causing a problem, then we could decide whether we could do limited surgery for that, or whether we could provide any other treatment that may sort of ablate or try and control that tumour as far as possible. And that may be in the form of radiotherapy, which I'll talk to you a little bit about later. But if it's not limited progression, if it's just sort of large volume progression, so none of it is responding to the treatment, then we would recommend that we then move on to sunitinib, which is funded and approved as second-line treatment. If you progress, or if the GIST gets worse despite sunitinib, then we have access to regorafenib, which is third-line treatment. And then the ones below the regorafenib here. So we've got ripretinib. Unfortunately, that is not NICE approved. So at the moment, we don't routinely have access to that drug. But again, that could be discussed on an individual patient basis, or we may recommend a clinical trial at this point of time if it's appropriate. So that's the majority of the algorithm. The one thing I haven't mentioned is the top right, and they're for people who have not got a imatinib-sensitive mutation. It is the minority, but you can get one of these mutations, gets a little bit complicated, PGFRA D842V. So the European guidelines recommend avapritinib, which is a drug that's specifically targeted for that mutation. Unfortunately, NICE did not approve that drug, so again, we don't necessarily routinely have access to it, but again, it's something that we may be able to discuss with the drug company if we think there'd be a patient that would truly benefit from that drug. And then there are other drugs available depending on specific mutations, but I don't think I necessarily need to go into that now, but feel free to ask me at the end of the talk if you had a question regarding one of those less common mutations. So trials, what have we got available? So locally, in our phase 1 clinical trials unit in Velindre, we're running the Target National Trial. So that's basically looking at a blood test that looks at circulating tumour DNA, and they do quite extensive genomic testing on that blood test to see if you've got any targetable genetic changes or alterations or mutations. And if you do have one of those mutations that we haven't necessarily got a targeted treatment available for on the NHS, then we'll try and see if there's a clinical trial available, an early phase or very early phase trial that may be available somewhere in the UK. So we may do the test, say, well, you have got this specific mutation that we think a drug might be helpful. It's still in trial phase. We don't know for sure, but we've got enough data to think that you may benefit from this drug. But you then may need to travel to elsewhere in the UK to access that clinical trial. Okay. And then these are the studies that I've accessed recently through the Royal Marsden, through discussion with Professor Robin Jones. So there's the PEAK trial, which I'm sure a lot of you are aware of. This is that drug that Nick was struggling to pronounce earlier. I feel as if I need to do a better job of it now. Bezuclastinib, and that's in combination with sunitinib for people who have progressed despite imatinib. And then we have also got one patient that I've recently referred to the Marsden for the NB003 trial. Again, it's an early phase trial, so it's very early on in the sort of progression of this drug, and it's really to see how effective this drug is. And it's a new small molecule tyrosine kinase 8 inhibitor. It hasn't even got a name yet, just a number. And that's for someone that has progressed on all available lines of treatment. So when we don't have any licensed or approved treatments available, someone would feel it is worth travelling to the Marsden to access this new drug on the chance that it may be effective for them. And I think, radiotherapy. Just the last couple of slides just to close this talk. So I talked to you a little bit about sometimes you'll be on a drug whether it's imatinib or sunitinib or regorafenib, and the majority of the GIST is responding, but there may be an isolated lesion which is growing despite treatment. And you think it's not enough of an issue to completely change the line of treatment to say conclusively it's not working, because it's obviously having some effect, but maybe there's a cluster of cells that have developed a resistance to that drug. So you're thinking, is there any way I can target that specific area to improve sort of overall outcomes? The other, and that's when we sometimes, if we can't operate on that lesion, we may offer radiotherapy. The other scenario where we may offer radiotherapy for patients with GIST is because a low dose may be useful for pain or bleeding, for example. So what is radiotherapy? Well, it's high energy X-rays. You can't see them, can't feel them, you can't smell them, but it causes DNA damage. And the aim of that DNA damage is to then cause a fatal change to that cancer cell to stop the growth and proliferation. It is an useful treatment for selective GIST patients, and it is shown to be a radiosensitive disease. As I said, low doses may be useful for bleeding or pain, but high doses can be useful to sort of ablate or stagnate the growth of a localized lesion which is enlarging. But it's a very sort of personalized approach. And there's one patient recently in exactly this scenario where we referred them through to the SABRE team. So it's a group of clinical oncologists that are based in Velindre Cancer Centre, but I suspect they'll be based in many of the cancer centres throughout the UK. And they've got a specialist interest in stereotactic ablative radiotherapy, which is just a sort of complicated term for basically saying that we're trying to give as high dose of radiotherapy as possible in a highly targeted format to the tumour, with the aim of giving as much dose as possible to the tumour, but sparing the normal tissue that surrounds the tumour to try and reduce the chances of any side effects from that treatment. So you're trying to spare the surrounding healthy, normal tissue. And it's normally delivered over just a small number of treatments, possibly 1, possibly 3, possibly 5, for example. But they really are very high doses of radiotherapy, every fraction, every treatment. And we've seen some very good responses with radiotherapy. Okay. That's the end of my talk.
I'll grab the other one. Is that working? Yes. Is this working? Okay. You're going to turn me up a little bit. Yeah, you can hear me all? Everybody can hear me? Yeah, good, okay. Thank you very much. So we do have some questions, don't go anywhere for a second. We've got 5 minutes of questions. Just one thing I wanted to say, you mentioned the NICE single technology appraisals earlier, which is where there is approval or not for drug treatments. Now, one of the first things I got involved in was a NICE technology appraisal for imatinib, where they were at the time offering 1 year, and it was being appraised to see whether or not they could give it for 3 years. So I went on behalf of GIST Cancer, representing patients as one of the trustees of GIST Cancer UK, and sat in a NICE technology appraisal. Have you ever been to one? No. So I'm sat there in a room where there's a long table with a chairman at the left. We're sort of sat in the middle, and there was about 15 people sat opposite me and a few people either side. What I didn't know was 10 of these 15 people were health economists. Their job was to persuade or otherwise the decision makers at the table whether or not that drug should be used for, in this case, 3 years rather than 1 year. Basically, to me, they were evaluating how worthy my life was about whether I should have that drug for 2 or 3 years. When they finished, I then said, the chairman said to me, Mr. Buntis, have you got anything you'd like to add? And all I said, quite simply, was, well, I'm just really pleased that you've now stopped talking about how worthy my life is of receiving this drug. The chairman stopped the appraisal, apologised to me, and said, we need to re-look as a committee about how we're appraising these drugs, because you're right. The vast majority of people in this room are looking at the cost-benefit analysis of whether this drug should be given to patients like me. And I believe from that day, they changed the way in which the evaluation of these NICE appraisals and how much more they gave to actually the human being rather than just the cost. So, and then they approved the drug for 3 years. So I'd like to think that I talked earlier about how GIST Cancer and what we do as a charity. That just happened to be me there at that appraisal. We have done others, but that's the sorts of things that we do on your behalf to try and, try and help us all. So, anyway, that just a little update, because I'm sure you probably wondered, some of you, what NICE appraisals meant. So that's what they do. So we've got about 5 minutes. Any questions? There'll be another time to ask questions towards the lunchtime break after we've heard the second presentation. But any burning questions now for Dr. Thomas? Yes. Hang on, we ought to do this. Just a minute. The videographers have a go at me if I don't.
Thank you. Hi, I'm from Caerphilly, and I know you have specialists in Velindre, so do you actually operate at Velindre?
No, it's the sort of non-surgical management of cancer that we specialise within Velindre. So if you needed to access one of the tyrosine kinase inhibitors, one of the drugs I was talking about, you'd come to Velindre. Or if you needed radiotherapy, but it's not a surgical centre. So surgery could be done in your local health board. Sometimes if it's a particularly complicated operation, because it really depends on where the GIST is, how big it is, whether it's invading any other sort of healthy tissue, you may need to travel for that surgery. But mostly it's done locally.
Yeah, I was denied to be seen by a specialist.
Right, okay.
So I was actually treated at the Cardiff University Hospital. Yeah. And that was because they wanted a student to see my tumour. Oh. And I wasn't treated good at all.
Okay, I'm sorry to hear that.
It was unhygienic. I had a nurse coughing over me because he wasn't wearing his mask.
Oh,
I was treated appallingly. And, I really think that we should be able to go to one of the others. I mean, I would be happy to travel, Swansea, whatever. Yeah. But I wasn't given that opportunity, and I think something needs to be done.
Sure. So the Heath, University Hospital of Wales, the Heath is a centralised surgical centre. So it is the specialist surgical centre. But obviously if you weren't happy with the care that you received there, then you should definitely, discuss that with the patient liaison service or the Putting It Right service. Or, I'm sorry to hear that you've had such a bad time.
I know there's a few people in the room that have got questions, concerns over the care that they receive. A couple of people that I've spoken to already, so maybe we can pick this up privately afterwards, because we'll know there's a generic element to it.
Yeah, of course.
There's also quite personal scenario. So, yeah, we've got a couple more questions here. Yep. Hang on.
Yeah.
Hang on. So the video can hear you.
Can I just ask about the imatinib? Yeah. At the moment, you're saying that, for 3 years, and I've been told that it's that I'd be kept on it for 3 years. Is it worthwhile if you could continue, say, for 5 years, to take it for longer?
Yeah, so that trial will be published soon, although it may take a couple of years to get the full results through. And that might tell us for sure that 5 years is beneficial, and that would take any element of doubt. Any decision about continuing the treatment for longer without the evidence to back up that decision has to be made carefully, because it does depend a little bit on side effects of the drug, how it's affecting you in your day-to-day life, and are we sure that you're truly going to benefit from it? Because at the end of the day, in medicine, it's do no harm, isn't it? So it is a difficult discussion, but it's certainly something that can be discussed on a personalised, individual basis.
I'm just going to take one more question here. We'll all right. Hang on.
So I've just come to the end of the 3 years, and I did question about whether I could stay on for 5 years. So I had a second opinion at Birmingham, and the 3 reasons that I was given was, first of all, imatinib, you can become resistant to it. So I don't know whether whether you've been given that information. Secondly, there are effects to your heart, and I can't remember what the other thing was, but there were good reasons, because I questioned, if there is a trial going on and I am high risk, could I stay on for the extra 2 years? But they gave me good reasons for not continuing until the results are out from that study.
Yeah,
So.
and if you've had that discussion, it makes you feel more informed about the choices that are made on your behalf. And if you're comfortable with that, then it's much easier to accept to a certain extent, because it is, it's a scary time when someone's making decisions on your behalf. You want to be ultimately sure that they're right decisions for you.
Okay, I know there were some more questions in the room, but we will have time at the end, and that might link into what Dr. Walters is going to say anyway. So if you don't mind, if we can move, thank you very much. We'll come back in a second.